Hi, my name is Elena Benison. This is my final project for the Quality Improvement and Patient Safety course. As I began the reflection and brainstorming process to initiate my quality improvement project, I found out quickly that I am an early adopter by nature. I was looking at some of the problems facing our facility currently, and I was really drawn to the big issues. I was looking at our current model of providing rehabilitation, how our students fit into that model, the use of patient-reported outcomes measures, increasing effectiveness of care, and I was wanting to jump into all those things with both feet, with really no regard for the simpler process that's required to bridge the gap. As we went through the class and I was made more aware of some of the steps that are required to bridge the gap and how to break down your project to make it more manageable, I quickly learned that there was no one way to address any of these issues. I found out quickly that it will take a great deal of time, that these changes are harder than I initially anticipated, and that was both exciting and frustrating. I was able to use this process to break down some of the larger areas of concern that I was seeing into a few key areas to focus my project and my thoughts. The key areas of concern that I identified were a lack of patient-centered care first and foremost. We were concerned mainly with the volume of people that we were treating on a given day. As a result, we were seeing some athletes who weren't making the progress that they really should or could be in rehabilitation. We had a lack of communication between our athletes and our athletic trainers. Our athletic trainers had some significant time constraints as we're shorthanded at the time. There were also some issues with a willingness to implement changes in our facility. While the key areas of concern that I addressed fit many categories of the STEEP criteria, I felt that enhancing patient-centered care provided during morning clinic and rehabilitation would be the most effective way to make a meaningful change in our facility. I decided to implement and incorporate global rating of change scales into our facility. I feel that this would be the best way to enhance communication between the athletic trainer and the athlete, increase patient satisfaction, and enhance the relationship between our clinician and our patients. With my general goal and key areas of concern in mind, I decided to implement global rating of change scales. I chose a global rating of change because it's a simple scale that's easy to comprehend, it's very efficient and saves a lot of time. The results are easy to interpret, and in this case they fit into our electronic medical record. They're easily specified to an injury, in contrast with a multi-item or injury-specific patient-reported outcome measure. They are open-ended questions that are unbiased, and the open-ended nature requires enhanced communication from the athletic trainer and the athlete in order for them to be effective. I felt that global rating of change scales were a simple and going to be an efficient way to impact the key areas of concern that I addressed. The team members involved in this quality improvement project will include our head athletic trainer, who is our manager for our electronic medical record and also consults most of the time with our team physician, our intern athletic trainer, who assists with the supervision of our morning treatment clinic, our 5 graduate assistant athletic trainers who are responsible for reviewing the documentation as well as overseeing the rehabilitation of their individual sports teams in the morning clinic, our athletes who will be completing the global rating of change scale, our athletic training students, who would be the ones distributing the global rating of change scales during our morning clinic, the team physician, who may be responsible for seeing athletes who are not making progress as we expect as reflected in their global rate of changing scores, and then myself as the assistant professor of athletic training, who would be providing education for our athletic trainers and athletic training students to allow and enhance the implementation of global rating of change scales. Most of the members of our quality improvement team are involved in the daily rehabilitation process. A given rehabilitation session looks something like this. The athlete will arrive at the athletic training facility between our morning clinic hours of 7 a.m. to noon. They check in on a kiosk in the waiting area and wait for an athletic trainer to get them. They're then assigned to an athletic training student. If the athlete is receiving rehabilitation, the athletic training student will provide their rehabilitation or treatment. The athlete will then sign up for another treatment if it's necessary and check out. After the athlete leaves the facility, the athletic training student completes the documentation or the rehabilitation note on that given day. The athletic trainer is responsible to review and approve the documentation. If the athlete is not receiving rehabilitation, a different intervention may be applied, be it ICE or discussion of a concern, maybe an insurance issue. After that's resolved, they would check out. The intervention or the meeting may be documented if necessary, and the athlete would leave the facility. Where our team physician fits into this plan is if we have an athlete who is not making the progress that is expected, they may be sent to see the team physician. He's also responsible for providing approval for rehabilitation notes for billing. There are a few key issues within this process that are related to people, methods, procedures, and environment. Related to the people, our head athletic trainer spends most of his time on administrative duties, indicating that our graduate assistants receive very little guidance or direction. They also cover a lot of sports and have many athletes on their hands. Our athletic training students carry out the rehabs most of the time, so our athletic trainers spend less time with their athletes. We have some frustrations with communication between athletes and athletic trainers, led to by students carrying out rehabilitations. Related to that, in our methods section, our athletic training students often conduct our rechecks and reevaluations on a daily basis. The athletes may not be as familiar with the athletic training students, and the evaluations may not be as effective or as meaningful. Thus, some of our data that we collect is not as useful or used as often. We are lacking documentation, and then we really make few changes based on our previous treatments or progress that the athlete has made. In our procedures, we treat all athletes from 7 a.m. to noon. Our athletic training students, again, typically complete the rehab and the documentation. We are treating a lot of patients in a very short time frame, which makes it difficult to provide really good quality care. Our current full-time staff have been employed here for many years, so we have used this model for a long time, and we are resistant to make any changes. After considering and reflecting on the current issues that I saw and our key areas of focus, after I decided to implement global rating of change scales, my initial plan was to try and achieve 90% of all athletes completing their global rate of change scale by the end of April of 2017. After, like I mentioned, I learned to back off and kind of focus down my plan on bridging the gap. I decided to narrow my focus and my aim to implement and utilize global rating of change measures with 50% of men's and women's basketball athletes receiving rehabilitation and treatment by April of 2017. Currently, there are no patient-reported outcome measures used in our facility. Thus, an improvement would be shown as any implementation of a patient-reported outcome measure, and that would be a change that we could make that would result in an improvement. I plan to use a paper spreadsheet to track the number or percentage of athletes who are completing the global rate of change scale, and an improvement specific to this process would be shown as an increase in the percentage of global rate of change scales completed. As I addressed in my key issues, there are also some concerns with communication between the athlete and the athletic trainer, as well as quality of care. So over time, as I expand this process, I could also expect to see improvements in communication, in patient satisfaction, in patient-reported outcomes, as well as just the outcomes of care. Those are all some things that I could look at further down the road to measure improvement in this process. To ensure that the changes made are improvements, I will be using the Plan, Do, Study, Act cycle. My plan is to begin with an educational session for the certified athletic trainers. I plan on doing a lunch and learn type meeting. It's difficult for everybody to get together at a given time in our facility. Right after morning treatments, when they end at noon, is a great time. Get everybody together for lunch, and it's just a good environment to discuss some of these concerns. I plan on talking about some of the challenges that we face currently and allowing a brainstorm session to bring some of the current concerns the athletic trainers may have to light. I plan on talking about different types of patient-reported outcomes measures and their benefits. Hopefully I can find some correlation to the concerns that the athletic trainers bring to light, including things I saw, such as a lack of communication and increasing our patient-centered care. I also want to discuss the benefits specific to the global rating of change scales, including the efficiency, that they're open-ended and easily interpreted. I plan to use my early adopters to encourage infusion to the rest of the clinicians. As I mentioned, we have some resistance to change, so by using the early adopters and the people willing to try new things, I may be able to have the other clinicians see the benefits and be willing to integrate it with their own patients. For implementation, I plan to use electronic scales which can be integrated into the electronic health record. They will be completed on iPads at the beginning of treatment sessions. We have the iPads available currently, and they will be completed on a weekly basis. The results are available for immediate use in the treatment note. This allows the athletic training student completing the note to include that score, so when the athletic trainer reviews the note, they can see it immediately and make changes for the following treatment session, or perhaps schedule a meeting with that athlete if they need to do so. The do portion of my PDSA cycle begins with the use of global rating of change scales. As I mentioned in my plan section, they will be completed at the beginning of rehabilitation sessions on the iPads and can be recorded directly into the electronic medical record. I plan to use staggered implementation, which I will discuss again in the spread plan, based on interest. I'm going to begin, as I mentioned, with the early adopters, as I feel that will allow for some infusion. During this cycle, I will request that the athletic trainers using the global rate of change scale will report their completion rates. I expect that they will report the athletes who currently complete the global rating of change scale, as well as the number of athletes that they treat. Unfortunately, EMR tracking is not available until I have the full staff integrated, so that's not something that's available at this point, so I will have to rely on the reported values from the athletic trainers. The study section of the PDSA is to determine the completion rate as reported by the athletic trainers of the global rating of change scale. My goal for each of the cycles is to have 90% of the population that is currently supposed to be completing the global rating of change scale completing it. In the later phases, I will identify completion rates per sport to identify if there are any issues with individual sports, and then I plan to have the athletic trainers in to brainstorm and assess the process that we've been going through. I want to identify any challenges that we're having, if we have technological issues, if we are using the patient-reported outcome measure to implement changes. Some potential challenges that I see arising are a lack of use. We currently only have 2 iPads available, so if there are 6 athletes in receiving treatment, it may be a challenge to get an iPad to each of those athletes at the beginning of their treatment. There are times when athletes are not assigned to an athletic training student immediately, and they are instructed to warm up and stretch before they begin their treatment, and they may be missed in the process. The novelty may wear off, and after it becomes more common, we may see less implementation, and then if the results aren't utilized or they're deemed ineffective or useless, it really defeats the purpose of the process. So I want to ensure that all of these challenges aren't occurring and try to find ways to combat the issue if they do begin to occur. Following my study section, I plan to act on the challenges that we found, as well as progressively add athletic trainers. If we achieve our 90% goal of all athletes included completing the global rating of change scale, I plan to continue to increase the athletic trainers and the athletes that are involved. Again, I'm planning on basing my athletic trainer additions based on interest and willingness. I feel like that will be the most effective way to ensure that we continue to use the measure, and then I want to make sure in each of my ACT cycles that I address, correct, and deal with any challenges that we found as we were brainstorming in our study section. The spread plan within my facility, again, is that staggered implementation. So I want to add athletic trainers as they become interested and as we achieve 90% of our current populations. I plan to continue using lunch and learn sessions to support the challenges and the barriers that we find, and to also encourage use. I feel that it would also be effective to add athletic training students to the lunch and learn sessions, as I feel that they would be a key component or a key team member in ensuring that the global rating of change scales are completed. So again, as 90% of our population that is completing the global rating of change measure, is achieved and reached, we would add additional athletic trainers and their athletes that are associated with their given sport. With time, this would spread through our entire facility, and eventually I would like to have 90% of our population completing the measures for their athletes. I appreciate you taking the time to review my project. I look forward to hearing all of your comments, your questions, and concerns.